cette invitation qui m'honore. Je regrette sincèrement ne pas être avec vous, surtout Alger, qui est une ville que j'adore, mais ce sera pour une prochaine fois. Donc je vais chercher I will try to show my screen. One moment. Share screen. This one. Share, and then this. Okay. I hope you see my screen correctly. After a short introduction, I will speak about the present and the future of theranostics, and essentially will have some word on the situation in low and middle income countries, and then some conclusion. I have no conflict of interest in this setting. So just a few words to remember that theranostic means the use of the same radiopharmaceutical but a different radionuclide for diagnosis and therapeutic targeting, and that the nice aphorism, we see what we treat and we treat what we see. For the diagnostic aspect, we have the chance of visualize and characterize and measure biological process, like the previous very nice talk from Egesta showed, at molecular and cellular levels in human and other living systems. So for treatment, we use either alpha emitter with non-reparable double strand and DNA breaks, so very effective but also toxic, or beta emitter with longer range and single strand DNA breaks. What is important, I think, that we have to consider, especially in low and middle income country, is the requirement for theranostic clinical application. First of all, the nuclear medicine physician role. I think he should be expert in oncology. He should have interdisciplinary cooperation and in particular participate in tumor board. And he should be able to follow up the patient, not only for easy pathology like, for instance, thyroid cancer, but also for more difficult aspects like in neuroendocrine tumors. The second aspect is internal dosimetry. What means dosimetry? Means to calculate the activity to be administered in order to achieve the desired effective dose. So it's the key of course, personalized treatment and of course also of the modern nuclear medicine. However, if we look at external beam radiotherapy, the absorber dose to target can be precisely calculated. However, in contrary, for radiopharmaceutical therapy, the situation is much more complicated. And also, according to recent communication from physics, the tumor absorber dose cannot be really calculated for many reasons. This is not the topic, but I think that if we want to start to do theranostic, we have to consider if to do or not to do dosimetry. The advantage of doing dosimetry is, of course, is the base of personalized medicine. There are also some legal requirements, especially in Europe, and I think that we need absolutely randomized trials. Why not to do? Because it's too cumbersome and not for the moment fully clinical validated, I would say. It is not indicated in the product characteristic, although there are legal requirements, and mainly big pharma is not interested. So this is a decision that every scientific society should take before considering this aspect. Let's look at the present. I would like just to mention here some key theranostic treatments that are now standard in high-income settings, but could be next frontier for implementation in low and middle-income countries. The first is the bone pain palliation with radium-223. The idea is to palliate patients with painful metastasis, and radium-223 is a calcium analog, so its uptake is essentially newly formed bone, and the alpha particle are able to irradiate adjacent tumor cell. The second is the neuroendocrine tumors. The target is somatostatin receptor, And for diagnosis, we use gallium or copper. For treatment, lutetium or yttrium. The technique is well known as peptide receptor radionuclide therapy, and it was the first theranostic implication that emerged about 10 years ago, more than 10 years ago. For prostate cancer, that is a little bit more recent, we target the transmembrane protein with a pharmaceutical that is PSMA that can be labeled with gallium in diagnosis and lutetium in treatment. This is really effective, and we can treat and see and treat as this nice picture shows. Now we move in advanced in theranostic. In nuclear medicine, we have the big advantage of have a combination of radiopharmaceutical that can be infinite. We can target practically all the aspects of the physio and pathologic field. You can use new radionuclides beside the classical lutetium or yttrium, like bismuth, lead, thorium, terbium, that there are many more. I like particularly terbium that is called the Swiss knife, not only because it was produced in Switzerland, but also because you can have in the same element, of course with different isotopes, the possibility of doing alpha, beta, auger, SPECT and PET. New treatment modalities, for instance, association of non-radionuclide treatment, like for instance external beam treatment, but also immunotherapy or chemotherapy, standard chemotherapy, or using our method, our radiopharmaceutical treatment at early stage. And this is really very important because, as it was shown before, the first treatment is the most important, not only for lymphoma. And then we have new diagnostic modalities like whole body PET-CT or PET-MR. I would also cite the artificial intelligence that could help us a lot, especially I think in the dosimetric cumbersome calculation. So the first idea of this new therapeutic modality came from prostate cancer. Normally we treat the patient in metastatic stage, but the idea is to advance and also either treat the prostatectomy with lutetium, that is called lutectomy. This is a trial that is ongoing with good results for the moment. Another very important and impactful new modality is the target alpha therapy. Here again I show you prostate cancer, but it's not only related to prostate cancer. With tandem therapy actinium-lutetium, this could enhance the treatment efficacy while not affecting too much the toxicity, because pure alpha therapy in prostate cancer are shown to be very toxic for the patient. We have a new radiopharmaceutical that is the FAPI. In this case, we label the fibroblast activation protein inhibitor, and this can be labeled in diagnosis with gallium or FDG. And this product is called the new FDG. It's the new FDG because we can have images of good quality, also in cancer that were not suitable for FDG. So the cancer can be, for instance, the breast of the stomach, but it seems that at least early stages show that the therapy evaluation is better rather than with FDG, and mainly we could have possible theranostic approach, because of course with FDG you can only have the diagnostic aspect, and the therapy you will do with the standard chemotherapy, like it was shown for lymphoma. You cannot label FDG with a therapeutic radionuclide. While with FAPI, we could replace gallium, for instance, with lutetium. So this is something that is interesting, and In 2021, I could read this article where Novartis, that is a big pharma, is very involved in theranostic nuclear medicine, has bought a license, and the idea is to have therapy with lutetium and also bismuth. And now we move to the core of that is also the end of my talk. The core of my talk is the theranostic in low and middle income countries. And we will see together what are the strengths, the weakness, the opportunities, and the threat. First of all, the key challenges for theranostic implementation in those countries are, first of all, the clinical and technical barriers. We know that we are limited access to dosimetry expertise, to equipment, that hindering the treatment personalization. We have also regulatory gaps and restriction on handling, storage, and disposal of radioactive waste. But I think the biggest technical barrier is represented to the high cost of radiopharmaceutical, especially those kind of radiopharmaceutical that are involved in the theranostic aspect. We move to structural and economical constraints. We have insufficient infrastructure for production and quality control, high development and licensing costs slowing local innovation, again, and limited awareness and integration of theranostic with the broader medical community. So there is also a defect of communication. So what are the way forward? I think there are some strategic priorities. First of all, to develop regional networks for radiopharmaceutical production, dosimetry and training to enhance self-sufficiency. And I think that Africa is a very good example of that, with some leading countries. Algeria is one of them, South Africa also, so for both French or English-speaking countries. These are leading networks that can enhance the activity of the whole region, continent. The second is the harmonize and simplify the regulatory framework governing the radiopharmaceutical, radiation safety and waste management. This is very important locally. Sometimes the regulatory frameworks are too cumbersome or too expensive to apply. We have also to encourage local manufacturing and technology transfer to reduce costs and improve access. This is also very important. This happened, for instance, in South Africa, and I think that Algeria has the capacity of doing this too. To integrate multidisciplinary collaboration among nuclear medicine, oncology, and medical physics professionals. This Congress is an example of that, and I think we should increase this kind of interdisciplinary collaboration and communication. We should embed theranostic within national cancer control strategies and public health policies, not to be something that comes from outside. It should be in your national cancer control strategy. Ensure reliable supply chains for therapeutic and diagnostic isotopes. This is fundamental, of course. Expand education and continuous professional development for physicians, physicists, and radiopharmacists, of course, and technologists. Establish sustainable financing and reimbursement models. This also is important in low and middle and essentially low-income countries where the patient financing is poor, and we have to find some fund to provide treatment for those patients. Reinforce infrastructure for dosimetry, quality assurance, and radioprotection that are always to be taken into account, and promote global and regional research partnership, ensuring strong participation for low and middle income countries. This is also another key aspect in order to move, and the example of the two presentations before, we have to participate in research. So in conclusion, theranostic is a paradigm shift for individualized high effective cancer treatment. The implementation in low and middle income countries is not simple, although there is a rising cancer burden, but limited access. So it's a very important problem, strategic problem that should be addressed. We have strategic framework that matters. Beyond technology alone, we have to be inclusive, sustainable, and systemic. And the key enablers for success in low and middle income countries are the regulatory reform, clear, harmonized, approved, and safety pathway, reliable radiopharmaceutical production and supply chains, workforce education and continuous training, and sustainable financing and reimbursement models. Then, systemic priorities, strength infrastructure for those